There's a huge number of things that are threatening the world at the moment. You actually witnessed one threat in the past and you are now fearing another involving TB. What is this?
I have spent 25 years in Africa. When I went to Malawi in 1986, I went to a country that had a tuberculosis problem, many other problems, and it was the start of the HIV/AIDS epidemic in Africa, 1986. So I remember very well that the national TB program, well established in Malawi, would see about 4,000 to 5,000 cases of tuberculosis per year. And then HIV hit us, and it hit us very hard and very quickly. So to give you an example, in 1986, we had a prevalence of HIV of 0.something% in the adult population. In 10 years, that had risen to 14%. 1 in 7 adults in Malawi had HIV infection.
What did that do for TB?
The main thing it did was escalate the number of TB cases. HIV depresses your immunity. TB's basically, if you have no immunity, TB germs multiply and activate, and you get active tuberculosis. So in 15 years, we saw the number of TB cases rise from 5,000 to nearly 30,000 per year.
Now, here in Barcelona at the conference, you've been talking about another comorbidity of TB with diabetes.
Absolutely. So very interesting. So in fact, we have another major pandemic occurring, diabetes. And if I give you some facts and figures, Peter, in 1980, the world had about 150 million diabetic patients. 2013, that is 33 years later, we have 380 million diabetic patients globally, and by 2035, it is predicted we'll have 600 million.
Again, what is this doing to TB?
Well, interesting. Most people said it doesn't affect TB because diabetes is a disease of the rich and tuberculosis is a disease of the poor. That perception is totally wrong. So if you look at those 383 million people with diabetes, 80% live in low and middle income countries. People say to me, it's the rich in those countries who are getting it. Wrong. It's the rich, okay, but it's also the urban poor who are at risk of tuberculosis.
And what have you found needs to be done?
Well, first of all, what we found is that if you have diabetes, you have an increased risk of tuberculosis that is 3 times higher than the normal population. So you put this together, then what will happen, we think, and we're beginning to see this, is there'll be an increase in the rise of tuberculosis, just like we saw 25 years ago in Africa. So we're describing this as a potential looming epidemic of diabetes and tuberculosis.
So are cases being missed at the moment?
I'm quite sure, absolutely. I mean, if you look at the data from last year, 1/3 of the TB cases in the world are missed. It's the missing 3 million cases. And if you look at those 383 million diabetics, half of them do not know they have the disease. So we believe in what's called bidirectional screening, Peter, where in patients with tuberculosis, you screen for diabetes, and in patients with diabetes, you screen for tuberculosis. In that way, you can pick up some of these missing cases. But can I just go on? It's also important because if you identify somebody who has diabetes and TB and you don't do anything about it, those people have a much worse TB treatment outcome.
And you have some initiatives going, don't you? For instance, in India.
Absolutely. No, what we did in 2011, this is a result of 2 years' work with the World Health Organization, the Union, support from the World Diabetes Foundation. We developed what's called a collaborative framework for care. And then we decided to move that to action in China and in India. So just to give you some example, in India, we went there, very nice system. We screened 10,000 TB patients and found that 13% of them had diabetes. And the other way around, screening diabetic patients, we found an increased risk of tuberculosis.
And how is the situation different in China?
It was exactly the same in China. In fact, exactly the same. We found exactly the same relationships in China as in India.
Now, in terms of implementing the strategies that are needed to tackle these challenges, both in places like India and places like China, what are the techniques that you have found to be effective?
Well, you know, you've got to convince policymakers to say, listen, this is an important problem, we need a policy directive. So we presented all the data in India to the government, the Ministry of Health, Director of the National Program, Director of the Non-Communicable Disease Program. India was very bold. They made a policy decision to say, we will test all of our TB patients for diabetes. That means testing 2.2 million TB patients every year for diabetes. It has cost implications. Now, implementation doesn't always follow immediately from policy. But we know in some states, for example, Kerala, that has been implemented, and my colleague presented data 2 days ago.
And it's been a bit more difficult in China?
Interestingly, China, we presented the evidence to China. China said, we're not prepared to make a policy, national policy decision. We continue doing the work where you're working, expand to other sites, expand to rural areas, come back to us with information. So they have yet to make a national policy decision.
Briefly then, could you sum up the things that need to be done to take action to face up to the challenge of this looming co-epidemic of diabetes and TB?
So very quickly, we've seen if you take action against HIV in a high HIV TB burden area like Southern Africa, you can get the tuberculosis burden down. So actually what we have to do is take action against stopping people getting diabetes. Very difficult, Peter. Lifestyle change, more action, better diets, etc. Yeah, and I'm afraid the increasing urbanization that's taking place in the world mitigates against those changes happening. But if there's a political will, I think we can get a handle on that.
And your message, very simply, to health teams would be what?
I think remember or get to know that diabetes and tuberculosis can coexist, and diabetes can increase the risk of TB, and TB can make the treatment of diabetes much more complicated.
And it goes without saying that you need to persuade governments to do something about the causes of diabetes.
Absolutely. I mean, I think governments are beginning to address this. There was a big UN summit on non-communicable diseases. We've got targets. We've got, we want to reduce premature mortality by 25% due to non-communicable diseases by 2025. The thing is action. Policies and plans go nowhere unless they're implemented. The best way to implement is to have people monitor and have to be accountable for what the monitoring is. So if you have a target, you've got to try and reach that target. I think that's what will drive action, I think.